Hello and welcome to this week's episode of For the Love of Chiropractic, Resources for Your Success. My guest today is a very, very special guest and a dear friend of mine. We have today Dr. Jeffre Rose. Dr. Rose has been a board-certified medical radiologist for well over 30 years. He has additional training as a body imaging specialist. So what that means, while he does all of the things a radiologist does, including some of the interventional radiology procedures, he also did a fellowship in body imaging. So when it comes to looking at some of the fine details of an MRI and what's there and what's not, he is arguably one of the top experts in his field in the United States. So without further ado, let's get started with today's show. Welcome to Season 3 of For the Love of Chiropractic. Season 1 has 60 episodes of practice management tips to help you build the best practice possible. Season 2, 3 keys of my success, 50 interviews with the most successful chiropractors from around the world. Season 3, resources for your success. So let's listen up and learn how to build a great business. So I had the opportunity to catch up with Dr. Jeffre Rose by phone. Jeff, are you there?
I am here.
It is so good to be chatting with you. And obviously, I know you and I catch up quite a bit because we have been friends for the vast majority of our lives. And I appreciate you taking and making the time to do this interview today. So you've been a radiologist, as I said in the introduction, for well over 30 years. And just to give the audience an update, so you started, your first job out of residency was where?
My first job, the market back then was a little bit different for jobs. My first job was running MRI centers in the Baltimore area. It was open MRI. It was a new concept at the time. And so it was 3 centers and 15 to 50 MRIs a day is what I would do for 3 years. And then I took a job with one of the largest groups called Advanced Radiology, which had 100 radiologists. And in that group, we had 25 offices and we covered about 13 hospitals. So I became a utility player and I became a musculoskeletal radiologist then. That's what I was doing back then. And then about 20 years ago, I moved to the beach and I've been enjoying my life at the beach. So I went from 100 radiologists in my practice in Baltimore to 10 radiologists here by the beach. So it's a little less stress, nice lifestyle out here.
So now, and you say that very nonchalantly, but again, having been there, I happen to know that you're now one of the senior radiologists in that group. And from our conversations, you've also told me that the volume of studies and films that your group does is unprecedented in the vast majority of the United States.
It's the trend now is, as you know, it's order more and more imaging. And in this population at the beach, it's one of the largest retirement populations in the area. So we're getting a lot of retirees out here. So we went from, trauma cases that were trauma at the beach, falling off your bike, very resort-oriented imaging to now more chronic debilitating diseases and chronic pain, which you guys deal with all the time. So the practice scope has changed, and so has our imaging. What also has changed is the utility in the emergency room. So when I first got here, I would cover an overnight shift, maybe do 10 cross-sectional imaging, CT MRIs. Now we do 50 a night. So we outsourced our evening work because of the amount of volume. So, and that's changed over 30 years, of course, is the amount of people ordering studies and the amount of volume that we have to deal with as radiologists.
Wow. All right. So as you mentioned, chiropractors often deal with chronic pain as well as acute injuries and acute pain. Mm-hmm. So approximately 50 to 75% of chiropractors still do plain film imaging in their own office. And when I say plain film, obviously I mean digital, not old school, film
Right.
and darkroom. I guess my question is this: if a chiropractor sees something odd on an X-ray, what's the first thing they should do?
Having known you for years and seen your area of expertise over time, What's important is, if you don't know, to ask. Chiropractors are really good at communicating with patients. And so I try to bring that, what I learned from Robert, is to communicate that type of way, not with patients, but with colleagues. So I would recommend not being afraid to talk to a radiologist, getting an opinion. The first thing they're going to always say is we always have to criticize the quality of films when it doesn't come from us. But the answer will still be, harder to see sometimes, but the answer will be there. Or, always can repeat the X-ray at one of our type of sites that is a little bit more, controlled than what we do. So the first thing I would do is look at your quality of images. If you need to repeat the film, flexion extension views, which I'm sure you guys do, are really important for stability. And then the question is, do you order more advanced imaging? And that's the big concern is when do you order and what to order, I think, for a lot of the chiropractors I talk to.
All right. So I wanted to get into that in just a minute, but you said something a moment ago. Don't be afraid to get an opinion, whether you're asking another colleague, so chiropractor asking chiropractor, hey, what do you think of this? Or in general, would you say radiologists are open to, the chiropractor walking in and saying, hey, I want to say hi and introduce myself. I practice in the community and I refer people to your center for imaging and I wanted to meet you face to face. Is that a normal thing or is that outside the box?
No, completely normal. I get that a lot. What's changed, though, is the practice. So where I used to be at the hospital or one of our offices every day, now you can do a lot of remote work. And remote work, what it allows us to do is use our time more efficiently, reading multiple centers. So if I'm doing intervention, of course, I have to be at the site. So it's a phone call. If it's not in person, say, hey, I'm Dr. So-and-so, a new chiropractor in the community. Every once in a while, if I have an X-ray question, would love to be able to ask you your opinion. And that's, start the conversation, either on a phone or an email or something like that. Or you can always try the imaging center, but I'm telling you, where we used to have, 10 radiologists covering everything, now we have 8 doing the work of 12. So we're not at the centers as often anymore.
I didn't realize that. Wow. Thank you. Mm-hmm. So, all right. So let's go back to the film. So I saw something odd on a film. And it's some sort of bony thing that doesn't look right. Okay. And while chiropractors, are certainly trained to, to do some differential diagnosis of, is it cancer? Is it not cancer? What type of cancer is it? Mm-hmm. I think it's safe to say the vast majority of chiropractors in practice, while we can recognize that doesn't look right, exactly what it is, because we're so far from boards, mm-hmm. we could spend the day figuring out. So my question is, what is the next test? Is it a CAT scan? Is it an MRI with contrast, without contrast? What should the doc be thinking about ordering towards?
It depends on the clinical question. One thing I hate as a radiologist is getting the clinical question saying back pain, low back pain. Okay. I get that, which is 90% of the time. If I get something specific, I used to tell my residents, when the clinical question is sharp, the report becomes sharper. It's true. If you tell me the patient has acute pain less than 6 weeks, then I would start with a plain film. That you do in your office. If it's lasting, if you notice a bony abnormality, then of course CT would be the best choice. But for a pain that's persisting despite your best, clinical intervention, then you're going to look at more advanced imaging like MRI. But if you don't give me a specific, if you make it back pain, my report's going to be so, generalized. If you tell me there's an L5 radiculopathy that's progressing, there's progressive neurological symptoms, there's something going on that I can kind of focus my attention on, it really helps both you get your answer and me figuring out from imaging what's going on.
Well, I just learned something. Thank you very much. With that, when I write the slip for an MRI, to put a more detailed history in that line, or I guess even attach a separate page if necessary, because some of the imaging centers that we refer to here in Baltimore, don't have much space. It just says, reason for study, and there's a small blank.
Code. Right, and then a code. a
Yeah.
medical insurance code, right?
Right. That's really interesting. So yeah, thank you. That's going to be very, very helpful. Okay, so let me ask you another question. So you see films, obviously, or so excuse me, you see orders come in, from chiropractors, from the hospital,
Mm-hmm.
from the ER, from obviously from medical doctors that are out in the field. When previous imaging has been done, especially plain films from a
Mm-hmm.
field practitioner,
Mm-hmm.
if you had to take a guess, what's the most common thing that the non-radiologist misses on a film?
I to put it kind of bluntly, it's not. You're going to look at the spine, right? What I find is don't forget to look at all corners of the film. Outside the clinical course, if you're worried about missing a clinically significant item, it's typically not where your eyes are focused. You're going to be looking at the spine. You're going to be at the alignment. You're looking at the facets, the degree of degeneration versus age. But you'll be surprised how many cancers I've picked up over my esteemed career that are on the corners of the film, that are on the top of the first image on the CAT scan, that really makes a significant impact for the patient's outcome. That may be not related to their ongoing concern. So I always say you're going to look at spine, you're going to look at alignment, look around the film, make sure you're not missing something that will come back to be something significant for the patient. Um, I always feel when I see it's a chiropractor, I'm like, what information can I give that will help their scope of practice, right? Because as opposed to a internal medicine doc, they're not going to really understand subluxation or alignment as well as you guys. So it really, I make my report, I dictate so you would understand, more so than a primary care doctor would understand the report. So I'll say it's a spondylolisthesis and anterior listhesis at 3 millimeters, L3 or L4. I'll talk about the neuroforamina, things in more detail that I may not, to get through the day, I may not do in every case. So my scope changes knowing that it comes from a chiropractor, orthopedic surgeon, or a neurosurgeon overall.
That's really
You got
interesting.
you
That's
got to
really,
get
really
through.
interesting.
You got to get through the cases. You got to read them.
Yeah, so sometimes I'll see a report, coming from an imaging center, or even sometimes orthopedic surgeons, and the X-ray report will say, straightening of the cervical spine,
Right.
degeneration at multiple levels, normal film.
Yeah, but it's funny. So that's the other thing too. The whole world has degenerative change, right? So if you're trying to help me decide if something is clinically significant, you got to tell me that the radiculopathy is on the left, if you
Hmm.
can. And it might not. Thinking about it from my perspective, we got a new electronic medical record system. So I have to now dig to find out more clinical history, even though the information from different centers is now available for me to look at. So it would be useful to know where you would write that for your imaging center. If you put an ICD code of back pain, that's all I'm going to see sometimes. So make sure your note is seen. Maybe call the imaging center and say, if it's not obvious to you, where do you write your clinical history on there?
Yeah, that's really cool. Again, the old school paper slip, has a line, but it's not
Right.
a very big line. Yeah, so
Right.
you're certainly not writing a short case history. But yeah, that's very, very helpful. So let's let's take a few minutes and talk about some of the interventional radiology work that you do. While it's obviously outside of the scope of chiropractic, when you started doing more and more interventional radiology, and you and I were just speaking socially, I was amazed at some of the things that radiologists are doing. So can you talk about some of those different procedures?
Well, when I did body imaging, what we do is use ultrasound or CT typically to find the abnormality and stick a needle in and get some tissue. So it depends. Now what I'm doing, we hired our first PA about 2 years ago to help the volume of the scut work that I call. So I would use ultrasound to drain, pleural effusions. I would do 4 or 5 of those a day. I would put in PICC lines, external IV lines. I would do 5 to 10 a day. All the stuff that you don't need my expertise for. So now I have a PA that does a lot of the paracentesis draining, the ascites for chronic liver failures and cirrhosis, to the pleural fusions, to the PICC lines, and that allows me to do more advanced stuff. So what I'll do now, my day is, I've even trained our PA to do some of the thyroid biopsies, again under ultrasound. So we use imaging to guide the needle to biopsy. I still do a lot of breast work. I ablate tumors, so if you have a renal mass, I can put electrodes on the mass and electrify the tumor, kind of shrink it down. Nice smell in the room, by the way, when that happens. So a lot of the work these days is we do a lot of breast diagnosis with my assistants, and we do a lot of biopsy first diagnosis. It's easy for me to get a lymph node that's superficial, deep enough that you can't feel it. So I shouldn't say deep, superficial, but it's a deep lymph node that I can get to safely using ultrasound to make a diagnosis, rather than do a search and destroy operative procedure or wait for the PET scan. So I'm doing a lot of biopsying, a lot of tumor biopsies, drainages. I'm still doing a lot of abscess drainages, and again, wonderful smell, and a lot of ultrasound and CT work is usually what I do. My scope of practice is not. We have one chiropractor out here that works with interventional radiologists to do some nerve blocks. I don't do that, but that's certainly what I've heard of as a collaborative kind of effort for pain. But it's fun. I get to, I get to gross people out and take out big needles and suck out pus. There you go.
And that's why you went to medical school for all those years.
I went to medical school. Yeah, my daughter said, "Why do you want to?" She's 13. She's like, "That's disgusting." I'm like, "Well, no, it helps people."
And your daughter is how old?
She's 13 now.
Yeah, exactly. All right. So you and I have also talked about that it can be frustrating for you when you get it, when the emergency room will send an imaging order to you.
Yeah, I think I know where you're going with this, but I can give you my take. The way that medicine is practiced I feel in the U.S., emergency room care is get them in, get them out quickly as possible, get a good Press-Ganey score, get good ratings, and move on to the next patient. The quickest way to do that is to have a triage nurse say they have back pain, order a CT or an MRI before clinical exam, get the study done, and then you get the clinical exam while the study is being interpreted or when the ER doc or the PA is available. So we're doing a lot of, we call it, scan them, get them in, get them out. And so that's why I think we're radiating a lot of the population, is everybody, it's quick to get a CAT scan. Of course, it's expensive, but it is pretty fast. Our turnaround time is usually pretty quick. So especially for stat cases. So it does get an answer, a clinical answer, but it used to be, I would get a concise right lower quadrant pain diagnosis. Now I get abdominal pain, and it's up to me to kind of figure out what's going on.
So, and when they send you the case of abdominal pain, are they ordering, for example, just an abdominal CT?
Oh yeah, with and without contrast, if the patient can take it. So that's our nights usually. Having an elderly population, I would tell you see this in clinical practice too. I must read 10 to 20 head CTs a day on elderly patients that fall every day, 365 days a year, without fail, except during the blizzard we just had. But it's a constant, and I see overuse of imaging from this, because everybody has to get a CAT scan that has a head injury. So they get a head CT and a cervical spine CT routinely. And you'll look at their chart and you'll see they've had 15 head CTs in the past 4 or 5 years. And
wow.
You would think that the core issue, I think, is what you see and you have to deal with is, try to stop this from happening and look at why this is happening. I don't see that at all. I see 15 to 20 head CTs. I'm like, yeah, there you go. And I have an old age report now. It's very standard to say, Power Scribe CT brain old age. So my standard old age report will come up. It's good for 90% of the population.
So
that one line and that one study, I get $100 for as a professional fee, and the hospital gets $2,000. So the incentive, of course, is to keep on scanning them.
So for the chiropractor in clinical practice, patient comes in and they'll typically say something like, yesterday or a few days ago or a week or 2 weeks ago, I fell. Okay, patient fell. And they're a person of middle or older age, we'll say. So let's say 50 plus. If the person, whether they did or did not hit their head, the chiropractor will do a full exam, do a physical exam, all the chiropractic things, orthopedic tests, neurologic tests, including cranial nerves. If the cranial nerve test or neuro exam comes up normal, and the person, say, hit their head, would you say they still need a CAT scan?
No, unless they're on blood thinners. But that would be the only caveat. If they're on, a lot of people are these days are on blood thinners, you may want to be more have more precaution with that. Of the 10 to 20 head CTs I do a day for elderly people that fall, even on blood thinners, the rate of bleeds is extremely low.
Mm-hmm.
And typically it's apparent neurologically. Sometimes it's silent, but a lot of times it is apparent, that you would see something clinically. So for the most part, unless the patient has other risk factors, that you have to make sure the fall isn't, based on something that could be a tumor or something unusual,
right.
The red hair. And I think a lot of imaging is done for the red herrings, right? A lot of the imaging that I do is to rule out, we know there's not going to be a bleed. Let's make sure, again, we miss a tumor, that's going to, I think a lot of imaging is done to kind of protect yourself from the potential miss that's extremely rare.
Right. But, the practice of CYA.
Yes. Yeah. You don't want to get sued. So for the most part, no, you don't need. I think you can get a lot of information on a X-ray, particularly if you're looking for spinal injury. Another thing that gets on my nerves on the ER side is CT of a lumbar spine in the middle of the night. If there's a compression fracture, I will see it just as nicely on a X-ray, and most of the time there's not. But if there is one that looks like there is some retropulsion, then you can get an imaging study more advanced. And your $100 X-ray, it becomes a $1,500 CT if we start with the CT. And a lot of times I call the ER all the time. I'm like, what extra information am I giving to you from this CAT scan? And they're like, well, we just get it done quick and get the patient out. I'm like, okay. So I find that it's, for me, I used to call the ER a question. Now I just it's not worth it anymore. Just read it. But over utility of CT, particularly for lumbar injuries, it happens routinely too.
Right. Well, you talk about overutilization of the CT. It's also a factor of 10 or 100 times more radiation to the patient.
Yeah, and we like I said, we like to radiate everybody. So from a chiropractic standpoint, MRI is your friend for most of your radiculopathies. I comment on abdomen and pelvis CTs. The field of view includes the lumbar spine. So I will see, compression fractures. I'll see, with contrast, I can see discs sometimes that are very obvious. So again, it's sort of like I said, the corners of the film. So from your standpoint, if you say, God, I would love to get a CT scan of the lumbar, and they had an abdomen pelvis CT the week before, you call a radiologist and ask them to look at the CT, see if they can find anything in the lumbar. If they can't, they'll tell you to order another study. But that might save the patient some money and still get the same information.
Right, and as a clinical practitioner of over 35 years myself, the patients always appreciate the doctor, the chiropractor, going that extra step and saying, you know what, let me see if I can get the information I need from these films that have already been done, so we don't have to radiate you again.
Yeah, I always, and then a problem that I see is that people don't know that the patients don't tell their clinicians that, oh, by the way, last week I had an MRI of my spine, if they're in the emergency room. And now with some of the electronic medical records, I can see other centers and what they've done, which has been helpful for things like pulmonary nodules and cases that I won't need to follow up if they've been there for a while. But yeah, this is the fun of imaging, and my diagnosis of degenerative change of facet arthropathy and neuroforaminal narrowing may not fit with your clinical picture. How often does that happen? You'll get a report from a radiologist saying there's this, severe L5 neuroforaminal narrowing on the right, and your patient has symptoms on the left. So it's, imaging doesn't sometimes explain clinical symptoms, even though you would think that that's a significant finding. So
Right.
it's not the end all. It's still your judgment. It's your 35 years of dealing with patients, Robert. And you've seen this, I'm sure, that it's nice when it all fits.
Oh, yeah.
There's it's a nice collaboration between, pixel and hands. It's nice when that happens.
As someone said to me so many years ago, patients forgot to read the textbook, so the tests don't all line up the way they're supposed to.
Yeah, I can't tell you how many times I've said, well, it's definitely neuroforaminal L4-5 socked on the right. And I'll say, oh, no, I have left-sided pain. I'm like, well, there you go. What do I know? I'm just looking at pictures.
So, unfortunately, we're just about out of time. Do you have any final thoughts that you wanted to share as we close out this episode?
I think, again, it's a collaborative effort. You're on the front lines of dealing with these patients and dealing with their pain. You're looking more of a form. I'm looking, and biomechanics. I'm looking at, imaging. I'm looking at pixels, trying to decide if this is going to be clinically significant. So it's really, again, helpful for me to have as much information as I can. And if there's ever, and don't, feel intimidated to call a radiologist. I talk to a lot of our clinicians in the area, from chiropractors to the podiatrists to orthopods. It's a collaborative effort. So I always like knowing I was right or knowing I was wrong. It's a learning process. If there's an ACL injury that I'm like, well, he said it was partially torn. I'm like, well, there you go. I learned from that case. So it's a collaborative effort, and don't feel intimidated or to ask for either assistance on your imaging that you're taking from either a radiologist or from one of your colleagues, or just to give me a call. We're there to assist. If you find you're getting a bad attitude from a radiologist or from someone for whatever reason, find someone else.
There you go. So, yeah. Dr. Jeffre Rose, I can't thank you enough again for taking the time, making the time, sharing your knowledge and wisdom, and really, helping all of us, be better practitioners to give the patients the best care and health possible.
I'll talk to you later, Robert. Thank you.
Bye-bye. All right. And that's our show for today. If you have a question about today's show or your own practice, feel free to reach out at fortheloveofchiropractic.com. Before making changes to your practice, be sure to seek legal advice regarding those changes and regulations in your state. For the Love of Chiropractic is an RGF production, all rights reserved. And thanks for listening. Original music provided by Hunter Rich Music.